Hi, welcome to the WAVY Digital Desk. My name is Sarah Good, and I'm here with Dr. Daniel Cohen, Chair of Neurology at EVMS, and we're going to be speaking about National Stroke Awareness Month and what we really do need to know, and if you aren't familiar with, risk factors and identifying stroke signs, we're going to cover all of that. So, Dr. Cohen, thank you so much for coming on today to speak with us a little bit about strokes, just for the next 15 minutes or so, and sort of give people exactly what they need to know.
Thanks for having me.
I wanted to start, can you just talk actually, what is a stroke and if there are different kinds, just so people are aware?
So there's two major kinds of strokes. The most common kind is when there's a blockage of blood flow to a portion of the brain. And then the symptoms that somebody has from that depend on where in the brain the problem is and what areas, or what that area of the brain that's not getting good blood flow, what kind of function that serves. And so that may be weakness or some speaking trouble or visual problems. And so lack of blood flow would be the most common. That's called an ischemic stroke. And then the second type of stroke, which is less common, is from a primary bleeding event, where one of the blood vessels will rupture for various reasons, and then blood will accumulate and put pressure on the brain and cause some harm.
And in terms of, who perhaps is more at risk, it does seem across the board in any research I did before this that women are, predominantly the ones that are at risk here. Is that correct? Or is that just, right now who we're seeing, perhaps have more strokes?
No, in general, men are more prone to what's called atherosclerosis. So that is where plaque forms in the arteries. We often use the phrasing hardening of the arteries. And so men typically have more cardiovascular disease. In total, it's a similar process that causes problems to blood flow to the heart and causes heart attacks. So men on average are at a higher risk.
And, is there a certain age group where this is, more likely to happen?
Yeah, certainly strokes become more common with age. So unfortunately, stroke can happen at any age, even as infants or young children. But much more commonly would be people who are in their later 50s, 60s, and higher, particularly because that's when the plaque in the arteries tends to become more prominent, and folks who are, say, in their 20s, 30s, or 40s, if they have a stroke, it's usually from a very different kind of process. It would be much less common that substantial plaque has formed in the arteries by that point. Still can happen, and for example, people who have had type 1 diabetes since they were very young will potentially get premature aging of their vascular system and get plaque in the arteries. But the most common cause of stroke would be plaque in the arteries, and that overwhelmingly is much more common when you're 60 and 70 than it is when you're 40 or 50.
And is it genetic? Is it lifestyle choices that sort of lead to that?
Yeah, I think the important thing to know is that there's a lot of different causes of stroke, and so that's part of our job, is to figure out in someone who's had a stroke, what do we think medically was a risk factor for this, and what we call the mechanism of the stroke. How did this particular stroke happen? And then depending on the cause, there may be some risk factors that are genetic. So there are some people who have arterial problems themselves. The walls of the arteries become abnormal because of genetic factors. There are other people who the blood, because of genetic reasons, is more likely to clot itself. And there are some people, for example, who will get a tear in the wall of their artery. And there are people with genetic conditions in which the structure of the blood vessel, the strength of the walls of the blood vessel is different. And so anyone potentially with a bad enough trauma, for example, sometimes even on things like a roller coaster, can tear one of the arteries in your neck. But there are some people genetically who are much more prone to that kind of tearing for potentially a less significant jarring of the head or neck.
And, if you do have a stroke, are there certain signs that vary based on, female or male, or are there certain signs that everyone has?
No, so the signs vary really depending on where in the brain is the problem. And so I saw on the screen you had flashed the Be Fast. And so the reason why that's a good tool is that doesn't capture every symptom you might have as a stroke, but it captures some of the more common ones. So if suddenly, and really a clue to a stroke is there's a sudden change in ability, a change in function. So either that could be my ability to move one side of my body, my ability to talk correctly, to see. And so some of the outward signs then would be if you notice somebody suddenly has a change in balance, if their eyes all of a sudden don't look like they're aligning in the same direction, if now you see one side of the face look different than the other, if you were to ask them to lift their arms up, or if you notice, one side is moving normally, the other side is now hanging down. And so, for example, if you say put your arms up and see one side, falls down very quickly. If you're hearing somebody, all of a sudden their speech changes, and that may be the way they pronounce the words, their articulation, so they may slur, or they may the words themselves may be the wrong words, where the syllables may be put together in a way that doesn't form proper words, or the words are strung together in a sentence in a way that doesn't really make sense. And so and then there could be other symptoms, but those would certainly be among the most common ones. And so all of a sudden, if there's a sudden change in someone's ability to interact with the world around them, that would be a potential clue that it's time to get the emergency room.
And I've heard some people say, it's the worst headache they've had in their life, or something of that sort. I mean, if you are maybe a migraine sufferer or you do get headaches, I mean, have you heard, different patients or different people with that feeling?
Yeah, so the worst headache of your life, for us, that's kind of a buzzword that makes us think about a type of bleeding. So something called a subarachnoid hemorrhage, which usually is a weakness in the wall of a blood vessel that causes the blood vessel to balloon out. And so that if you can imagine a blood vessel that has a little outpouching where there's a balloon kind of, it's a structure filled with blood, but it's essentially the blood vessel has stretched. And if you can imagine just like a balloon, if it blows up too much, then the strength of the wall gets weaker and weaker and ultimately can burst. And sometimes that can happen even if it's relatively small. And so everyone at some point or the other will have their worst headache. But if your worst headache is still not all that strong, then we don't need to worry. It's really generally if you say I've had a bad migraine, but this is just like every other migraine, and yes, this is the worst, but they're all exactly this bad. That wouldn't be a reason to rush to the emergency room. But it's really the speed at which the headache develops. So if you go from no pain to within a short number of seconds or a short number of minutes to intense agonizing pain out of the blue, sometimes we refer to that as a thunderclap headache, where you're sort of struck by this force. That's really why when the worst headache of my life really means potentially this could be a bleeding event, and that kind of 0 to 60 in terms of pain is much more important than eventually if it slowly got there over hours or even days, and now it's finally reached its worst point. And yes, it's my worst, and it's technically my worst headache. That still wouldn't worry us like the one that happens in a split second.
Right. And, they say be fast, but if you are asleep, for example, or maybe someone does not notice the signs, is that, I hate to say lucky, but is it just lucky of when that stroke occurs, whether it's daytime or whether you're sleeping or whether you're around people that might notice a change?
Yeah, no, you're exactly right. Unfortunately, there is a matter of luck as to how quickly this can be noticed. And so the treatments we have now, there's really one is a type of medication, a strong blood thinner, usually in the class of medicines called TPA, or tissue plasminogen activators. And those are essentially strong blood thinners that help dissolve a clot. And then if we see a blockage when we do a scan, some people would be candidates for the interventional team with a catheter to go in through the arteries themselves and actually suction out and pull the clot out. And the faster you get to the hospital from onset, and the faster blood flow is reestablished to the brain, the less harm there is. And so if you were asleep for a few hours after the event, then there's less brain tissue that's likely going to survive compared to somebody who potentially got to the hospital in just a few minutes and got one of these therapies. And so time is a big factor. And in fact, one really important message, what we need to know when someone comes to the emergency room is not when we notice the symptoms, but what we go from is when was the last time this person was at their normal baseline, the last time they were well. And that's the critical time window. And so if they were normal an hour ago, and then found 30 minutes ago, that's very different than they were found 30 minutes ago, but it's been 8 hours since they were last normal in terms of our ability to safely give treatment. And now there are some types of scans that could help us narrow down that time a little bit better, and mostly in the sense of we can get a better sense of, are there areas of the brain that are not getting good blood flow, but that are still able to be saved if we can get blood flow back, and versus areas of the brain that are permanently harmed. And that helps us weigh the risks and benefits of a treatment, because as much as we want to help people with these therapies, if there are risks to these therapies, and if we believe it's unlikely that there's brain tissue that can be saved, we don't want to expose someone to the risks of these interventions.
And, I imagine how close you are to catching the stroke to the time it occurred, that drastically, changes the treatment process or the recovery process afterwards.
Yeah, so if you suspect someone is having a stroke, or you yourself, some sudden change in your abilities, then on average, the faster you get to the hospital, the more likely that you would be a candidate for one of these treatments, which are intended to try to save the brain from some of that damage, or even potentially completely save the brain from damage. Once the damage has set in and the tissue has been harmed, then that it doesn't really heal in a traditional sense. So people can recover from a stroke because the rest of the brain can compensate, and the brain can rewire and reorganize, what we refer to as plasticity, so that function can improve. But once the tissue is harmed, it's permanently harmed. And so getting to the hospital quickly gives you the best chance of minimizing how much tissue is harmed. And then really after that, the main focus of care is to try to make sure there's not medical complications. For example, if you have trouble swallowing, we want to make sure that you're not taking things by mouth that make you at risk for getting food and essentially infection in your lungs, where you're essentially literally at what's called aspiration, where things are going down the wrong pipe. We want to make sure you don't get a blood clot if you're not as mobile. So some of that early care is just to make sure that beyond the injury you've had, we don't get another medical complication superimposed. And then a big part of the hospital stay is making sure you're stable, making sure your heart function's stable, and looking into, well, what do we think the causes were? And that drives then the thought process behind what can we do medically to minimize the chance that you have another one. And so most people are either on aspirin or a medicine that works like aspirin, what we call antiplatelet medicines. That would be the standard, but there are some people who require a stronger blood thinner, older ones like warfarin, and now there's some newer ones, for example, apixaban and others. For example, if somebody has what's called atrial fibrillation, which is a heart rhythm problem, where the electrical pattern of the heart changes and the top part of the heart doesn't squeeze as efficiently as it should, so the blood doesn't move through the heart like it normally should. If blood doesn't keep moving, it'll potentially clot. And so for people with atrial fibrillation, we know that aspirin or medicines that work like aspirin are not really protective enough. And so people need a stronger blood thinner. But if we don't find a reason for a stronger blood thinner, we don't put you on it. So stronger is not better, because stronger blood thinners also make you more prone to have bleeding. So we're always trying to balance the medicines to try to minimize the chance you have another stroke, versus we have now caused a problem like bleeding because of our preventative medicine. So trying to figure out in any given person, why do we think you had the stroke, and then tailoring the medicine. That's really the approach. And then beyond the medical care, thinking about now if you're living with a change in your brain and you're weak on one side or speech trouble, et cetera, then can the rehabilitation team work with you to minimize how much that disrupts your life? Can they work with you on strategies to train the brain so that to improve the brain's ability to rewire and improve function? So that would be kind of the longer term view there of now living with in the rear mirror this has happened to you, and how do you maximize quality of life despite the event.
Right. And I did want to ask before you have to go, is there anything that you can do, whether besides medication, I guess, lifestyle changes or so forth, that can sort of maybe lessen your risk or help you?
Yeah, so a few common things, and these are probably not going to be surprising, but certainly diet plays a role, and we're moving towards Mediterranean types diets, so low in red meat, higher in fish and chicken as a meat source, lots of vegetables, fruits, lots of nuts, legumes, cooking with olive oil instead of other oils. So what we probably most of us would think of as a heart healthy diet, aerobic activity at least 3 times a week, not smoking, not necessarily no alcohol, but modest alcohol, usually a drink or less. And there's been a swing back and forth in terms of whether maybe just small amounts or it may actually have some benefit versus none. But certainly, I think everyone agrees that if it's more than somewhere in the ballpark of 1 drink a day on average, then now it's going to be certainly more risk than any potential benefit. Things like that are common, so people who snore very loudly, or potentially gasp or have pauses in their breathing during sleep. That may not just be a sound issue. That may be sleep apnea. That's a risk factor, something that we screen for, trying to keep a healthy body weight. Or others, we believe sleep itself probably, even if you don't have sleep apnea, not getting enough sleep has some cardiovascular consequences. So eating well, exercising, getting good sleep, staying active, probably, again, nothing terribly shocking, but easier said than done for most of us.
Right, absolutely. Yeah, maintaining a lower stress lifestyle and less busier lifestyle. I did want to ask the last thing is there anything coming out research wise that, seems to be either a new treatment method or seems to be new research on the horizon? I mean, is there anything that, changes year to year, I guess, or that is studied more frequently?
Yeah, there's certainly a lot of study in terms of the medicine side. And so that is, we mentioned if you get to the hospital quick enough and you can get a medical therapy, there are some studies looking to see, can we add on a second medication that you're given right away in the emergency room that minimize the damage? There are changes in the procedures themselves for trying to to remove a clot. We've now moved to a longer window where we think people can benefit. So it used to be that we thought if you weren't treated within the first 6 hours from onset, then there's potentially not a benefit. Now, even up to 24 hours, we're seeing a benefit. In terms of preventing a future stroke, there's been a lot of movement in terms of what's the optimal blood pressure targets. We're using statin medications quite frequently, even if your cholesterol level is normal. A lot of data now showing that helps minimize plaque in the arteries above and beyond just lowering cholesterol. There's more and more study looking at combinations of medicines, for example, aspirin plus another potential medicine that may work like it, whether that's short term or longer term. And so those are some of the things that do slowly shift over the years, and really a lot of science behind trying to figure out ultimately, can we treat you more effectively if you come to the emergency room to minimize the damage, and can we be better at prevention above and beyond lifestyle factors? And overall, I would say that certainly medical care today, in terms of prevention, we've come a long way in terms of reduction, but unfortunately, the stroke rates are still much higher than they should be, and will be as the science improves.
Right. And I just want to, give you the last word here. Is there anything for, stroke awareness that you think is critical, for people to know or take with them?
Yeah, I think other than really trying to, make sure you get regular preventative care, trying to do what you can with lifestyle factors. But if there is any sudden change in function, either yourself or someone that you're around, making sure getting to the hospital very quickly. Don't wait to see if it improves on its own before you go. Time is brain, and really trying to get to the hospital quickly, and making sure you convey to either the EMS team or the emergency room physicians the time that everything was last normal, not just the time where you noticed the problem, but when was the last time everything was normal. And what we really need to know up front is, are you already taking a blood thinning medication that helps us make very quick decisions? And so I think that unfortunately is something that we don't always get the best information right up front in terms of the timing or medications that somebody's on at the moment that potentially make receiving one of these blood thinner emergency treatments more dangerous.
Well, thank you. Thank you, Dr. Cohen, for speaking with us about this. I know that this is an issue that occurs in a lot of people, not just unhealthy people, but healthy people as well. So I think just if people keep in mind some of those tips, hopefully that will, reduce someone listening, or they'll know how to look out for the signs.
Right. Exactly.
Absolutely.
Thank you for having me.
Thank you so much. And thank you to everyone for joining us.